Dr. Salas obtained his degree in medicine in 1996 from McMaster University. He completed his postgraduate training in neurology at McGill University in 2001, followed by a clinical research fellowship in behavioral neurology and stroke at the University of Toronto. He joined the Division of Neurology at Sunnybrook in 2003 and served as director of the North and East GTA Regional Stroke Prevention Clinic from 2003 to 2008. In March 2008, he took a position at McMaster University, joining the Division of Neurology at the Hamilton General. In July 2008, he became the inaugural recipient of the MG de Groot Professorship in Stroke Management and also began a 5-year term as champion best practices across the continuum of care for the Provincial Coordinating Council of the Ontario Stroke Network, which is the governance body of the Ontario Stroke System. In January 2014, Dr. Salas assumed the responsibilities of Program Director for the Adult Neurology Residency Program and Fellowship at McMaster University. In 2021, he was recognized for his contributions by receiving the Department of Medicine Postgraduate Education Award, as well as the Undergraduate Education Award. In July 2022, he was promoted to full professor and assumed responsibilities as both Division Director for Neurology and Clinical Head of Service for Neurology at Hamilton Health Sciences. So I'd like to turn it over to you, Dr. Salas.
That was long. Now I feel old. Thanks so much. I'm eager to take some questions. Probably there are people on the call that I've met in the emergency room. So it's nice to be here. I thought what I could do is maybe I could start by cutting and pasting the questions I received and answering them one by one, like into the chat. So just to get us rolling. So I'll put this first question. We got about 10 or 12 questions. So one question, and if you recognize this as your question, just a little point of clarification, but the question is, why is temporary blindness, I think, or signs of a posterior stroke, i.e. failure of Hintz exam, not an indication for a pre-hospital stroke bypass? So I think, so temporary blindness, I think people can have temporary monocular blindness, and basically any temporary symptom, people would no longer be on a bypass protocol because it would be considered a TIA at worst. And in terms of the Hintz exam is tricky. I have a question for the audience. Are people performing the Hintz exam in the field? Can I ask? I don't like the Hintz exam, just so you know. No? Okay, yeah. So the Hintz exam is a test for patients who are experiencing symptoms of continuous vertigo to determine whether or not those symptoms of continuous vertigo are because of a brain lesion as opposed to just an inner ear problem. And the number one mistake people make, there's 3 components to it, we won't go into it. It involves looking for nystagmus and moving the patient's head and watching their eyes. And the number one mistake people make is that they do the Hintz exam on patients who have intermittent vertigo. Intermittent vertigo, or symptoms of dizziness that come on with head movement, is almost always inner ear. In fact, when we get referrals to the stroke prevention clinic for patients with isolated dizziness, we don't see them. We decline those referrals. When you think about what it would take for a stroke to result in dizziness, it would involve ischemia in part of the brainstem. And as you're all aware, the brainstem is packed so tightly with circuitry that you're not only going to get dizziness. You're going to get dizziness plus diplopia, or dizziness plus dysarthria, or dizziness plus limb weakness, or dizziness plus something. So if somebody is only experiencing dizziness, it's unlikely to be cerebrovascular, especially if they're experiencing dizziness that comes and goes when they move their head. In all likelihood, that's just inner ear malfunction. So I think certainly we wouldn't want to start bypassing people for symptoms of dizziness because it's kind of hard to interpret anyway. If it's going to be serious, they're going to have dizziness plus dysarthria, a speech disturbance. Hey, then they're going to bypass. Or dizziness plus a facial droop, then they're going to have a facial droop. Or dizziness plus limb weakness, right? So I think when dizziness is paired with one of the symptoms on the prompt card, then it's a more serious presentation. But dizziness in isolation is super seldom cerebrovascular in origin. I can't remember of any recent cases. Should I go to the next question as we're warming up? Go to the next question.
Actually, Dr. Salas, can I ask you to go back to the one that we didn't finish?
Oh, yes, do that. Yeah.
Yeah, so you mentioned, but that was obviously Dr. Shrivastava mentioned early in the presentation about how a change in LOC typically means the presentation might lean further away from stroke. Are there any cases where a significant change would lean towards a CVA?
That's a very good question. So in general, a stroke doesn't really impact level of alertness, an ischemic stroke, right? Because all you need is your brainstem or one hemisphere to be alert. So people come in with a right hemisphere stroke, you know, they're awake, they're alert, they're not moving their left side and they're neglecting, or they come in with a left hemisphere stroke, they're awake, they're alert, they're unable to speak, and they're not moving their right side. As you're all aware, when a person's level of consciousness begins to drop in the context of stroke symptoms, you're all nervous about an intracranial hemorrhage, right? Because what will decrease level of consciousness is increased ICP. An ischemic stroke, it takes days for the damaged tissue to swell. So you're not going to be seeing raised ICP in the field from an ischemic stroke unless you're picking up somebody that's been lying on their floor for a few days and they're at that stage. If somebody's cognition is deteriorating, not cognition, if the level of alertness is deteriorating en route, then you really got to worry about a hemorrhage, something that's, then you'll be looking for blown pupils and stuff. The big exception, and to get at you know, the question, is a brainstem stroke. So people that, and this is so important actually, people that have a loss of consciousness because of a basilar artery thrombosis, those are people we can actually help. So a basilar thrombectomy can really reverse everything. And if you don't do a basilar thrombectomy, the person can infarct their brainstem, be permanently disabled, be locked in, die. Like, it's very awful. But I guess in speaking with our emergency room colleagues, there's so many reasons that people might be brought in altered, they call them altered, right? And so because it's a minority, you know, the emergency physician is going to see first, and they'll usually do a quick CAT scan anyway. So I think we'll get to these patients with the basilar artery thrombi quickly anyway. When you're pre-notifying us, we head into the emergency room to try to be there when you get there or shortly afterwards. We're always there as consultants to the emergency room physician. Even though we're often the first person that you see, you're not really bringing the patient to the stroke neurologist. You're bringing the patient to the emergency room. The person who is most responsible is the emergency room physician, but because we realize that time is brain and the emergency room physician is perhaps busy elsewhere, we just head in there with the assumption that the emergency room physician wants us to see the patient. Ultimately, we're always there as consultants to the emerg doctor. So if you bring someone in that's altered or unconscious, the emerg doc will see quickly. They'll probably organize a scan quickly, and they'll be on the phone with us quickly. I don't think it's going to be a big delay. Are there spin-offs from that question? Not yet. Okay. Oh, wait. Is it true that a potential differential diagnosis for Bell's palsy can be tested with patient's ability to raise the eyebrows? I love this question. Okay. So, yeah, I mean, facial droop has gotten a bit controversial because facial droop in isolation, if it's truly a cerebrovascular event, we're not going to thrombolize, right? So, at its worst, facial droop is going to cause 3 points. Ironically, 1 point for a mild facial droop, 2 points for a pretty severe facial droop in an upper motor neuron pattern, 3 points for a facial droop that is a lower motor neuron pattern or Bell's palsy. So ironically, on the NIH stroke scale score, you get the most points for a facial droop that's not even a stroke. So many of you, have we talked about the fact that we now treat mild stroke with dual antiplatelet, not thrombolysis? Has that been discussed this morning yet? By Abby or anybody else?
No.
Rhonda? Nope.
No,
Okay.
go ahead.
This is huge, right? So, and this is why we might be looking at changes to the paramedic prompt card. A lot of cases of facial weakness in isolation that come in are often facial droop, and the paramedics don't know, could it be a stroke? So you call us, and we're actually reluctant to come in because it's often not an actual stroke. And moreover, even if it is an actual stroke, we're not going to thrombolize the person because at this point, it has been determined from something called the Aramis study. It's a few years ago now that loading somebody with aspirin and Plavix is equivalent to thrombolizing with TPA or TNK for NIH stroke scale scores of 5 or less. So, where thrombolysis was the only thing we had for any kind of stroke, mild, moderate, severe, for a few years now, we don't thrombolize mild strokes. We actually just give them aspirin and Plavix. And so do we even need to be pre-notifying the stroke service for a person that isn't going to be thrombolized? I'm getting off on a tangent here. But something that many of the emergency physicians need to be sometimes reminded about is with a Bell's palsy, a facial nerve palsy that is often idiopathic and not stroke related, the entire face becomes weak, right? So the upper and the lower part. So the question was, is it true that you can test for palsy by asking the patient to raise the eyebrows? And it's entirely true. So in a Bell's palsy, the person can't raise the one eyebrow. A Bell's palsy, there's weakness involving the upper part of the face and the lower part of the face. So in a stroke, you're going to get weakness only in the lower part of the face. You're going to get, the facial droop, but it's not going to affect the eyes. Now, the reason I love the question is that people are always taught, and physicians are taught in medical school, to check for a Bell's palsy versus a stroke by asking the person to raise their eyebrows. But the truth is, it's really hard sometimes to determine whether the one side is really weak. And one of the tricks, like for a very mild facial droop, that's very, very mild flattening of the nasolabial fold maybe, and very mild weakness up here, it's hard. People can kind of raise their eyebrows, but this is going to sound crazy to you. The only way you can tell that they're actually weaker is by feeling the forehead when they're trying to raise their eyebrows. And on the normal side, you can feel the ridges of the wrinkles. And on the other side, you flatten them as you try to feel them so it feels smooth. Now, you don't need to take it to that level. The key thing about a Bell's palsy, the key thing is that people can't close the eye. That's what people should be looking for. And so if somebody's got facial weakness, just ask them to close their eyes. And if it's a Bell's palsy, that eyelid won't close. It'll lag. That's the real key. So although people are taught in medical school, to get someone to raise the eyebrows, it's still a bit of a judgment call. what's so super easy is to ask them to just try to lightly close their eyes, and it's super obvious that one of the eyelids is weaker. So if you want to try to determine whether somebody is having a stroke or if it's Bell's palsy, sure, you could look, definitely eyebrow raising should not be affected in a stroke, right? Unless it's a brainstem stroke. But then they're going to have other symptoms than just facial droop. The eyelid closure is affected in facial palsy as well. Yeah, so that's a little pearl there. Okay, so I'm going to go to one of the other questions from the email. This is another great question. And it was, how do you qualify inappropriate words? Is it saying the wrong word? Having trouble finding the correct word? Is it gibberish? Is it all of the above? And I like that question a lot because, I like to talk about a speech disturbance, right, as a catch-all phrase. Aphasia gets bandied about. Like people say, oh, somebody's got aphasia. Aphasia means that language is not working. And in what way? People might have an expressive aphasia. They can't get words out. And the key thing about an expressive aphasia is that they're frustrated. They know the word they want to say. They can think the word they want to say. But it's almost like there's an invisible gag, and it's very effortful. It's like something is stuck. So someone with an expressive aphasia that's trying to say sock is going to be like, sock. It's like a real effortful thing. That's an expressive aphasia. Now, people often confuse expressive aphasia with receptive aphasia. And why is that? Now, a receptive aphasia is when you cannot understand speech. I mean, that's the core thing. But what's interesting is that when your brain can't understand speech, it can't even understand its own internally generated language. And so what happens with a receptive aphasia is people begin to spout gibberish, right? So it's an effortless gibberish. So a lot of medical students and emergency physicians call receptive aphasias expressive aphasias because the patient is not expressing themselves correctly. But an expressive aphasia is a motor aphasia, it's a Broca's aphasia, it's an effortful inability to produce speech, but what you're producing still makes sense, right? Like you actually can understand the word when it comes out. A receptive aphasia, when comprehension is impaired, the person has no clue what you're saying. They don't understand that they have no clue what you're saying. They're just spouting all this gibberish. Because the way I explain to medical students, because we call a receptive aphasia a Wernicke's aphasia, I tell them, well, people begin to speak Wernickean, right? So when someone is not making any sense, they're speaking Wernickean, right? It's this bizarre language, right? And it's like, oh, yeah, that gobbledygook is a receptive aphasia. It's not an expressive aphasia. And so that's, we got to get our aphasias straight, expressive versus receptive. Sometimes somebody is globally aphasic, and that they're usually mute, they can't say anything. And that's all distinct from dysarthria, right? So dysarthria is not a problem with language. Language is being internally generated and is being sent to the mouth to speak. But dysarthria is when the mouth muscles aren't working properly, so that people sound slurred, right? And you can kind of, understand the word they're trying to say, but their S's are shushes. And so, yeah, so in dysarthria, it's both aphasia and dysarthria are speech disturbances, and they're both very serious. And so if somebody has a speech disturbance, they need to come in as a speech disturbance, right? And is it an aphasia? Is it dysarthria? Bonus points if you say this person is aphasic or this person is dysarthric. A lot of times, just to be honest, we get the patch, and when they say aphasia, it's actually dysarthria. When they say dysarthria, it's actually aphasia. It doesn't really matter. We have to come in anyway. They're both serious, right? But sometimes people are dysarthric and they're just drunk. Like I've come in and people are just like, you've probably all been there as paramedics. You come in and the person is just slurring their words, and you ask, have you had anything to drink? And they're like, no. And you're like, I don't know, right? And I've had a couple people come in drunk, and so I mean, the emergency docs are pretty good about that. We're like, can you get a alcohol level? And then we kind of walk away. Let's let the emergency doc handle it. But the other really hard thing is people with dementia, because people with dementia, their cognition is impaired. And if your cognition is impaired, then you can't formulate your thoughts well enough to turn them into language. So, you're not making sense. So a lot of times we're getting people coming in from nursing homes with a speech disturbance or with aphasia, and often it's just someone demented that's not making sense, right? It's not that they have aphasia. Often we get the caveat, oh, but normally they're able to talk, but people with dementia, they can get intermittently confused, right? Confusion is different from aphasia. Someone with confusion will also have a speech disturbance, but it's all different stuff. So, I mean, that's my little, notes on inappropriate words. So is it saying the wrong word, having trouble finding the correct word? Is it gibberish? It's all of the above. If somebody is saying the wrong word, yeah. I think that's what I have to say about speech disturbances. Any follow-up questions on that? Yeah, I've got more questions here, so I'm going to go and copy and paste another one. This one is about an ocular stroke. It says, I would like to have ocular stroke or retinal artery occlusion discussed. Oh, yeah, this is a good one. We had a patient with a potential ocular stroke, but was out of the time frame for transport to the stroke center. If in the time frame, does the patient meet directives to go to the stroke center? So an ocular stroke, an actual retinal infarct, people call it a stroke in the eye, is different from an occipital lobe infarct. As paramedics, you're always picking up people who have occipital lobe infarcts. Where? You're picking them up after they've been hit by a vehicle, right? Because they've stepped into the road, because they got hemianopsia, or because they've fallen down the stairs, right? Because they can't see where they're going. So occipital lobe infarcts, which cause hemianopsia, you can't see anything on the right. If it's a left occipital stroke out of either eye, you can't see anything on the left. If it's a right occipital stroke out of either eye, people are usually unaware of hemianopsia. And so they usually come in with a subacute occipital infarct because they've gotten into trouble because they're hemianopic. And half the time, they don't even realize they're hemianopic. It's so weird because it's really that they see nothing and you don't really acknowledge nothing. So it's weird. But a retinal infarct, an occipital lobe infarct is, sorry, a retinal infarct, an ocular infarct is when you've got a clot in the retina. And that's totally different. All of a sudden, everything goes black in one eye. Either the upper branch knocks out your vision in the lower half, because the eye is like a pinhole camera, or the lower branch of the retinal artery knocks out your vision in the top half. It's dark shadow in the lower or the top, or a full-on retinal artery occlusion knocks out your vision totally. So the thing about retinal artery occlusions is that there's never been a clinical trial to establish that thrombolysis is effective. And because there could be other things that lead to a blackout in the eye, like a retinal hemorrhage, we would only ever consider thrombolysis if somebody was first seen by an ophthalmologist. So if somebody was brought into the general with an acute like blackness in one eye, we're not going to do anything until an ophthalmologist looks in that eye. So it might be almost better to take them to St. Joe's, right, if it's an ocular. If they have that, if the ophthalmologist looks and says, yeah, no, it's not a hemorrhage, this is a clot in the retinal artery, then we don't know what the best treatment is. We don't know whether there's risk of causing a retinal hemorrhage. It's so seldom treated. There's very scant accounts in the literature of people treating a retinal artery infarct with thrombolysis. There's no evidence to support the practice. Moreover, now that we know dual antiplatelet therapy is equivalent to thrombolysis for NIH of 5 or less, well, what's even the NIH score if it's going to be 5 or less? So is dual antiplatelet sufficient? So I think for a retinal artery embolus or infarct, there's no evidence to support thrombolysis, so we're not going to put those people on the bypass protocol. It's really important to get an eye doctor, an actual ophthalmologist, to do a dilated exam to make sure what we know what we're dealing with before any consideration of thrombolysis or dual antiplatelet therapy. And a lot of my colleagues are really nervous. I can count on the fingers of one hand how often I've even heard about someone like this being thrombolized. I think it's 2 or 3 times in 20 years. So that's, yeah, so it says here, if in the front, yeah. Is there a type of migraine that mimics a stroke? I love this. I love this. For example, they present with speech disturbance and acute confusion, memory impairment, but no complaints of a headache based on a previous patient. Gosh, you know, so absolutely migraine can mimic a stroke. So a lot of what we see in the stroke prevention clinic is migraine aura, but there are, I won't even call them nuances. There are clinical features that really tell you that you're dealing with migraine aura and not stroke. So there's basically 3 kinds of migraine aura: visual, sensory, and speech. Motor weakness, let's just say, is never because of migraine. Now, some smarty pants might say, oh, well, there's familial hemiplegic migraine. Yeah, it's a rare autosomal dominant position that people have had their whole life, and so has their entire family. So somebody with familial hemiplegic migraine, know that they have familial hemiplegic. It's not going to be that. So you're never going to get a migraine mimicking weakness. Now, sometimes people will actually say they feel weak because they feel numb. But let's get to the 3 kinds of migraine aura. So the first is visual. So migraine visual aura can take the form of just out of focus vision. A stroke is not going to cause out of focus vision. Now, somebody with an occipital lobe stroke who's hemionopic might say there's something funny with their vision and they don't know what's wrong with their vision. They can't really put it into words that they're hemionopic, and they might use the word blurry. But then you test them and they have good acuity and it's actually a hemianopsia. Actual, it's like your prescription has changed for your glasses and everything's blurry. That's migraine. That's not going to be stroke. Migraine visual aura will often cause what we call positive phenomenon: zigzag lights, flashing lights, sparkly lights. It'll cause the hallucination of something being there that's not. Like stroke doesn't do that. Stroke manifests in 2 different ways. Ischemia manifests either hemianopsia, if it's an occipital lobe, or amaurosis fugax, which is like that dark shadow coming down from the bottom, up from the top, or in the whole eye. That's it. So if it's some kind of sparkly lights, zigzag lines, colorful, something like that, it's either a retinal detachment or it's migraine, right? So you can get scotomata, blind spots, with migraine aura as well. And so the other thing about it is that stroke, they call it stroke because it's fast. Like 1 second you're good, the next you're not. Migraine takes time to build, right? So if somebody, let's suppose you're still worried about visual symptoms, but if the person tells you, yeah, I thought I saw something at the corner, but then I wasn't sure. And then a few minutes later, I thought, yeah, no, for sure, there's some kind of like line in my vision or something, or is it a circle? And then a few minutes later, it got bigger. And then a few minutes after that. So migraine aura just cascades gradually over the course of several minutes. So even just that tempo, it's not stroke. Stroke, again, it's like a lightning strike, right? All of a sudden you've got, maximal and onset symptoms. So migraine sensory aura is, the hallmark is tingling. So somebody will say, I think I got a little tingling in my face, or wait, I got it in my face, in my hand. Then again, minutes go by. Wait, the tingling seems like it's going up my forearm. More minutes go by. Yeah, it's kind of going up to my.
Code white.
Second, we got a code white. I don't know if you guys can hear it. It's so loud.
Code white. General Hospital. Emergency Department. Code white. General Hospital. Emergency Department.
Okay. So yeah, coming back to that. Let me just put this up. So yeah, and then sometimes as the paresthesias, the tingling ascends, then in their wake they leave a numbness. So it's all very different from, oh my God, all of a sudden I couldn't feel half my body, right? That would be like a thalamic stroke. There are a few exceptions. Very rarely there could be some tingling. Like if a thalamic stroke is kind of stuttering, then you might get numbness with reperfusion paresthesias. But yeah, the language thing. Can I share a YouTube video? Do you think that would be okay? I'm going to go migraine YouTube reporter. I show this once a week in the stroke prevention clinic. So there's a very famous Here, I'm going to, can I share?
Yeah, you should have, just remember
Okay.
to click share sound with video.
Okay, so what I'm going to do is I'm gonna go, oh wait, how do I share now? I've got it loaded up. I don't see a share. Where's the share button?
Along the top, do you see share?
Along the top. Oh, yes. Okay, here we go.
Yep.
Hit the share button.
And just ensure that you include sound. It'll say,
okay, I'm going to include sound. I'm going to turn it on. And now, is it letting me? I don't think, because I'm in, I have to actually get it in. This is so worth seeing, so bear with me. I'm going to open up Google in Citrix. So there's a very famous example of a reporter on national television in the United States who got migraine aura involving her speech. And so this is a good example of what migraine aura sounds like. So I'm going to put, again, migraine YouTube reporter. I don't know if it's going to come up on your browser, but I bring this up once a week. So here we go. Redirecting, you're being redirected to the page. Chrome extension. Please update your browser. Forget it. Okay, so anyway, so this is some self-directed learning. So if you want to see, her name is Serene Branson. If you want to see an example of how migraine can present with language disturbance, it really sounds a little bit like a receptive aphasia. The big difference is that the person is aware. With a normal receptive aphasia, where people are pronouncing gobbledygook, they remember, they're not understanding anything. So they're producing this speech and they don't know that they're not making sense. With migraine, they 100% know that they're not making sense. That's usually the big difference. So if you want to Google migraine YouTube reporter, that's how I usually bring that up. Okay, so let's go back to, let me close this. I'm trying to get very fancy there with sharing. Oh, you found it. Yes, thank you very much, Dr. Fraser. Yeah, I'm pretty sure that's it. I'm going to just click it. I think that Matthew Fraser put it in the chat. I clicked the button, nothing's happening. It's okay, anyway. Okay, let's continue.
I found it, Dr. Salas. I can try sharing.
Great. Yeah, try sharing it. It's great. Please, yeah. Okay.
So this is it.
The Grammys on Sunday, in her live report, we couldn't understand what she was saying, and many people thought at first, including doctors, that she had a stroke of some sort on camera, but that did not turn out to be the case, and we do know what happened to her, and David Wright is here with all that. Good morning, David.
Good morning, Robin. It turns out it was a migraine headache, but this is one of those there but for the grace of God moments for any of us in TV news. A stumble on the air that was so awkward, people thought she was having a stroke.
Well, a very, very heavy debatation tonight. We had a very Darrison bite. Let's go to Terrace and look for the head of the pit.
It was an on-air blunder that had people across the country wondering and worrying.
I was aware of, this isn't making sense.
You can stop. It's worth it to go back and see the whole thing. So I think that's a good example of a migraine dysphasic aura. So I mean, I think it usually doesn't last very long. There's usually a migraine type headache associated with it. The person is usually aware that there is something wrong. And there's some other features as well. The person's probably known for migraines. I think in the field, you're going to be a little nervous of saying, oh, I think this is just a migraine. But it's good for you to know that it is on the differential, and that's what it looks like. Okay, so going to the next question that was emailed, I'm going to copy and paste it. There we go, and it says.
So, Dr. Salas,
yes.
if you're a paramedic in the field and you have somebody doing that, it's much better to just treat as if it might be a stroke and then work through the other pieces? Absolutely,
yeah. We're very happy to see those people because migraine and stroke are both on the differential, but you know, we're happy to come in. The scan's going to be normal. You know, they're going to get the headache, and we're going to be happy to tell them that in the end of the day, it was not a stroke. So it's just more for awareness that migraine can mimic stroke. In the field, you know, that's you don't have to worry about sorting it out. Just bring them in, and we'll sort it out. But it's just more for knowledge that that it might sometimes be migraine. But again, we're very, very happy to see anyone with that kind of speech disturbance. 100% appropriate for us to come in and see. Yeah, so again, just to share that that's a possibility, but it doesn't influence who you're going to bring in or not. Okay, so going to the next question, it was, is there a further assessment beyond the LAM scale that can help assess for atypical strokes in the pre-hospital setting? For example, there are numerous triage acronyms for MCIs, and LAMS helps us with large visitors. I don't think so. I think LAMS is mostly looking for hemiplegia, right? And a large vessel occlusion, so a left MCA or a right MCA occlusion will typically result in hemiplegia, right? So I think it just zeroes in on that. I'm not aware of any other scales apart from LAMS that would be useful in the field. I think the kind of patients that, you know, the differential for stroke is at the top of the list is people with hemiplegia, right? Like there's very little that's going to cause a painless hemiplegia apart from ischemic stroke. Language problems, broader differential, right? We've talked about it. Vision symptoms, broader differential. Sensory symptoms, broader differential. So I think, yeah, I think that if a LAM score is high, there's a super high possibility that you're dealing with an actual large vessel occlusion. Yeah, I don't think that, I can't think of any other scale to answer the question. Sorry. I've got another question here about last seen normal. It says, what is the difference in treatment for last seen normal time when it goes beyond our 6-hour stroke alert? I think I heard Dr. Shrivastava dealing with this though at the end, like the so basically, just to understand a little bit about stroke treatment. So it used to be there was a 3-hour window, right? And then, you know, the number needed to treat was 8. Now 8 at the end of the window. So if you got people there quickly, because, you know, time is brain, every minute counts, your number needed to treat is lower. So the sooner you treat a stroke, the more likely that individual is going to improve to, you know, a complete or near complete recovery. At the end of the 3-hour window, it's 1 in 8 people that are really benefiting that much. Now, at the end of the 4.5-hour window, it's 1 in 14 people. So it's diminishing. It's not like football where you get to the end zone and you touch the football down and everybody wins the game, right? It's diminishing returns. So, you know, sometimes people are like, oh, quickly, we got to get this person in before the 4.5. No. If you're already at 4 hours and 29 minutes, you know, the likelihood of benefit is very little. Like that's why it's not, you're not going to rush to thrombolize somebody that's, you know, at the very end of the 4.5 hours. The likelihood of the benefit is really less. You're going to rush to get people treated early. What happened initially is that the EVT trials were within 6 hours. So then people were being notified because they might be a candidate for EVT if they're not a candidate for thrombolysis. Then it was determined that people would benefit as long as 24 hours after the last seen normal. But some of these patients will, like, there's a difference between witnessed and unwitnessed strokes. A witnessed stroke, the last seen normal and the symptoms first recognized is the same point in time because a stroke happens right in front of somebody in a witnessed onset. In an unwitnessed stroke, the last seen normal and the symptoms first recognized are separated. So last seen normal the night before, symptoms first recognized this morning. In unwitnessed strokes, the stroke might have happened before, you know, when they went to bed. And so even though the stroke symptoms were first recognized, you know, in the morning, when they get to the hospital, you know, the house has burned down. It's like, you know, the firefighter's not going to be able to put out, like, save a house after it's burned down. You know, therapy is not going to prevent a stroke when it's happened, right? Like, we're like a stroke is permanent brain damage. The brain is malfunctioning with the interruption in blood flow. We're trying to restore blood flow before the damage can become permanent. When, you know, there's been no blood flow for several hours, and it's a well-established infarct, there's no benefit to opening up the blood vessel. So some of these patients that were lasting normal 24 hours ago had their stroke 24 hours ago. There's nothing more to do when you bring them in the morning. Other people, their stroke might have been just before they woke up. You bring them in, and even though they're the same lasting normal, the duration of the stroke is, many, many, many hours less. So they bring them in, you do the CAT scan, there's no damage yet, full steam ahead because there's lots of brain left to save. It's the difference between a firefighter getting to a house after it's burned down and, getting to a house when the fire starts, right? So it's the exact same analogy. So what happens in the hospital is that if the patient's coming more than 6 hours, the emergency physician orders the CT perfusion. And the CT perfusion helps determine whether there's salvageable brain. And if there is, then they contact the stroke service, and then we see people. So that's the difference in the treatment plan beyond the 6-hour stroke alert. Endovascular thrombectomy is the only option after the 4.5-hour mark. But because EVT expanded our treatment window to 6 hours, then it was a 6-hour stroke alert. But then EVT is actually helpful out to 24 hours for people that might have had, maybe they have good collaterals, maybe they're hanging on, maybe the stroke isn't really 24 hours. Most strokes that are 24 hours old, there's nothing to do if they're truly 24 hours old. But there's a lot of people that the stroke's not really well established yet within that 24-hour period. So we're trying to identify the people where they're actually more recent. Like if somebody tells me, if you go as paramedics to pick somebody up, and the family says, yeah, they kind of became hemiplegic last night, and we thought that we just put them in bed because we thought they'd be better, and now it's the next afternoon and they're not out of bed yet. Well, last seen normal was within 24 hours, but I can tell you when you bring the patient in, there's just going to be a completed infarct on the scan. So the difference, it all relates to the unwitnessed onset and the true duration of the stroke. I hope that answers the question. CT for possible salvageable brain can determine. Yeah, so a regular CAT scan, a plain head, will show you a well-established infarct. You don't even need CT perfusion. If it's truly, I hate to use an analogy, but again, the house is all burned down, there's just that, you can see that on a plain CAT scan. But sometimes you see some hypodensities, there's some damage, but you don't know how much salvageable tissue is within the area of ischemia. And so CT perfusion can tell you, well, here's the area of ischemia, and here's how much of it is permanently damaged. And so there's a ratio. So a CT perfusion can help give you an idea of how much salvageable tissue there is when it's not completely damaged yet. That's to answer that question, yeah. Oh, okay, and then here was a little question about last seen normal. It was, what are some tips and tricks for determining last known well for stroke symptom onset? Yeah, I think the one thing to remember is what time was it, right? Like I think the number one pitfall for last seen normal is when somebody says, when were they last seen normal? Oh, an hour ago. Okay, off we go. Get to the, hey, we're bringing in somebody. When were they last seen normal? An hour ago. And then come to an hour ago. It's just an hour ago for an hour, right? So whenever we hear last seen normal, we don't want to hear something relative. We want to hear what time was it, an hour ago. And often this happens when I'm on telestroke or other things. When the person tells me it was an hour ago, and I'm like, how is it an hour ago? Their CAT scan was an hour and a half ago at your hospital. They're like, oh, wait a minute. No, it was, and then they realize they have no clue because they didn't actually ask the time. So I think the number one thing is what time did the symptoms begin? And if people are having difficulty, then I jog their memory with, okay, what room were they in? What room were they in? What were they doing? And that can sometimes, like if they have difficulty with the time, then you can pivot to, okay, where were they in the house? And what were they doing? And who was with them? And just to get a little bit of the biographical narrative helps jog people's memory. That's my tip there. Okay, so from a past call, last seen normal, a patient thought it was 24 hours ago, but the patient's wife, who has dementia but lives independently, saw him make eggs this morning, as per her claim, which put him in the 8-hour window, but Stroke Center stated it was not a reliable timeline from the wife due to her dementia, and therefore 24 hours since onset. Well, I mean, it's a bit of a judgment call. I mean, if I was getting this story and I'm hearing that the patient's wife saw him make is claiming that she saw him makes eggs, then I don't know about I would just take it at face value. Like me personally, I'm like, okay, well, I don't know how bad this woman's dementia is, and even if she has dementia, it could be that it's true. So I think that enters an element of uncertainty, and when a stroke neurologist is uncertain, they're like, bring them in. Like we're only going to get unenthusiastic about a case when we're sure, like, there's no debate that the person's out of the window. So when you're telling me that the patient's wife who has dementia saw him make eggs, maybe he did make eggs. How bad is her dementia? Like, I would just take it at 8 hours. Like, hey, 8 hours, 24, it's all within the window. But I think that's a bit of a judgment call, and you don't want to invalidate the eyewitness account because there's a allegation of dementia. What if you're wrong? What if they say, oh no, she doesn't have, a lot of times people get labeled with dementia and they've got MCI or something. Like, they're not actually, like, dementia is a broad term. Like, people can have severe dementia, be bedbound. People can have, I don't even like the term mild dementia. Like, I mean, it's just mild cognitive impairment. So yeah, that's how you felt. Yeah, well, we would have been in alignment there. So I think what my feedback there is, it would probably be case by case based on who you're talking to. But I think you ask a few different people, you're going to get a few different answers with that question. Okay, and then what is key information you need here? This question here is, what is the key information you need paramedics to communicate to you when bringing in an acute? Well, okay, so this is actually, so the key information obviously is the time. Like, I say three things. One, was it witnessed or unwitnessed? I think for me is the first thing, right? Because a witnessed onset, you have a known duration, right? So was it witnessed or unwitnessed? So I like to hear witnessed onset or found with symptoms. Then your last seen normal time is relative in those terms. So witnessed onset 2 o'clock, last seen normal was a moment before it was witnessed, right? Versus unwitnessed onset found at 2 o'clock, last seen normal the night before, right? So I think witnessed or unwitnessed is something important that's not emphasized enough, because witnessed, you know what duration of stroke you're talking about. Unwitnessed, you don't. And so last seen normal means different things if it's witnessed or unwitnessed. So witnessed or unwitnessed is an important thing that isn't talked about a lot. The last seen normal is always talked about, but whether it's witnessed or unwitnessed, has some relevance. Now, the last thing that I wish people were a little bit more specific on was seniors residence, retirement home, long-term care, nursing home. Surprisingly, when people are coming in, that's not as clear. I don't know how that's not as clear. So, like, are they in a nursing home? Well, sometimes it was a retirement home. Sometimes it's a seniors residence. Like, the amount of time that the level of care. So, in other words, what's their baseline status? So, there's a little bit of variability there. So, are they at home? Yes. I used to ask, are they independent? The answer was always yes, always. And then I would ask, well, do they need any PSW support? Oh, yeah. Somebody comes in every day to bathe them. But that's how they're independent, with the PSW support. So they're missing the whole thing. So I do not, obviously, someone's not independent if they have someone coming in every day to wash them, right? So I don't even ask if someone is independent at baseline anymore. I ask, do they get PSW support? That's the question I ask, because there's no point asking if they're independent. The answer is always yes. So, so after witnessed or unwitnessed and time last known well, I then ask, okay, are they at home or are they living somewhere else? If they're at home, do they get PSW support? Right, is my question. So, and that someone that gets no PSW support, maybe their spouse is really involved, but I mean, you're getting an idea, versus somebody that they have somebody every day. That's a difference, right? And then in terms of if they're not at home and they're living at a retirement home or a seniors residence or a nursing home or in their locked ward, like, I think that's all very helpful for us in terms of the baseline. So often asked in relation to when 911 call was placed. Yeah, that's actually a good tip. about the onset of time, because yeah, it's a timestamp to work from. That's a really good idea. Okay, I think we're almost through my questions. I have two more questions here, and one of them is, how do we recognize a posterior circulation stroke in the field? What can we add to our assessment to pick up patients? I think so. So a posterior, they're tricky, right? So a posterior circulation stroke is going to present with bilateral neurological symptoms in a declining LOC. Like they're almost like there's a whole bunch of different presentations. They can masquerade as almost anything. So, but in general, posterior circulation strokes will affect vision. But the problem there is people that have an acute hemanopsia are often not aware. The only way that they're made aware is if you kind of test their vision, and that can be kind of tricky. So I think certainly dizziness or vertigo in the context of dysarthria, diplopia. Again, in medical school, we're taught about the D's for posterior circulation. So dysarthria, diplopia, dysphagia. So dizziness plus some other neurological symptom is concerning for posterior circulation stroke. But if it's a true posterior circulation stroke that's going to get thrombolized, then you're also going to have a decreased LOC because of the, you're going to be getting ischemia in the brainstem, and then you're going to have a decreased LOC. So they're tricky. I think you're stuck. If it's a decreased LOC, you're going to come in quickly anyway. Like it could be anything. I told my emergency room colleagues that anyone with a decreased LOC needs a CT angiogram to see if the basilar artery, and they laughed at me. They're like, "Are you kidding? Do you have any idea how many people come in here with altered mental status?" Like, no, not everybody's not getting a CT angiogram. So I think I would just get them to the emergency room. And then again, remember, stroke physicians are consultants to the emergency physician. When a paramedic is bringing in somebody and it's a slam dunk, it's a stroke, we're nominally there at the behest of the emergency room physician. But let's not forget that ultimately, when they pass through the door, it's the emergency room's physician's patient, and we're the consultant. So have the emergency doc come in and see them quickly, and then they'll decide, they'll get a CAT scan and they'll call us really quickly. So, and then maybe this has been talked on briefly, but for us on the road, what would be your number one takeaway piece of advice for a stroke assessment proctor mistake? I can't think of anything that we haven't already discussed. I don't think that there's one takeaway piece. You guys have a really tricky and challenging job, and I think and you're already doing it so well. So I don't know that I would just say that there's lots of little curveballs that can happen. I would struggle. I think that if I was going to give you one takeaway, it's going to be my whole witnessed unwitnessed thing. Like I think it's really important for us to know. Like people roll in and they just say lastly normal. I think it's really helpful to know if it was I think that's the one thing I would add. And I have one last question here. So we'll have gotten through them all. And it says, are the signs and symptoms of a stroke in a younger person different than someone who's older? Are there different risk factors for the development of stroke in a younger person? So stroke in the young is defined as stroke under the age of 45, because certainly after the age of 45, it's very common to have strokes for the usual reasons, right? So, you have hypertension and diabetes and you smoke, after 45, all bets are off, right? Like, so now under the age of 45, we get people in their late 30s and early 40s who, again, it's the usual suspects. But we get a lot of people that are, in their late teens or early 20s. Like the thing I see the most is young women on the birth control pill who may smoke. And so on telestroke, I've seen a very sad number of serious strokes in young women. Like they tell me this is the name of the patient, there's the date of birth, and I'm like, she's 20 years old, this is not a stroke, right? And then I pull up the scan and I'm like, oh my God, it's having a stroke. It's usually women. So I think stroke in the young, I think women on oral contraceptive pills who smoke and may have other risk factors, those are the people that I've been really surprised. Oh my gosh, even though she's only 20 something, she's really having a stroke. I think in others it's drug abuse, right? Cocaine can cause strokes in people that are younger. So yeah, there are some different risk factors. The presentation is the same. Yeah, so I think, well, we tackled all of the questions that I was sent, and we got a few more, and I think we're at time, but I think we've tackled everything. So
Yes, thank you very much. So as you can see, I'm sharing the QR codes for people that would like to request a certificate, and we always love to get feedback as we plan these annual workshops for the paramedics. And thank you, Dr. Salas. It's been great. It's just wonderful to see. There's been lots of interactions with the Q&A. And yeah, so looking forward.
I want to really take a moment to say thank you to EMS and our paramedic colleagues, because the job is so thankless, and I see you guys roll into the emergency room and get attitude from people and stuff like that. I know your job is really hard, and just so grateful. We're not out there in the field going into houses and picking up people. Like, I just thank you for what you do. Just got to say that for sure.
Yes. Anyway. Yeah. Thank you, Dr. Salas. And yes, we want to echo that also from the Central South Stroke Network also, that we really value your work. Okay. All right, I'll stay on just for another minute or so, just if people want to get the QR codes or the links. But otherwise, have a great afternoon, everyone.
Thank you.
No, thank you.